Hello everybody, and welcome to this first webinar from Nox Medical on home sleep testing. This particular webinar is about balancing clinical accuracy and simplicity in home sleep testing. My name is Snorri Helgason, and I will be your host today. And with me is Dr. Erna Sif Arnardottir. I will give you a more proper introduction later on. I want to talk a little bit about why we are doing this. And as everyone knows, there is an ongoing global pandemic, COVID-19, which has, in a sense, forced healthcare systems to take a giant leap forward in kind of like modernizing and streamlining their patient pathways. And the demand has increased dramatically from patients for telehealth solutions. As we all know, home sleep testing and home sleep apnea testing is a part of a big telehealth network. And it's important for us to discuss how we can use home sleep testing to our advantage in sleep, and how technology providers, how the sleep field, how sleep scientists should be taking advantage of new technology, and what we should be aware of. Because today's technology advancements have brought a lot of opportunity to all of us in bridging gap between what is now called in-lab PSG and home sleep apnea testing. It has been deemed not as accurate, home sleep apnea testing, as polysomnography, and rightly so. But is it necessary to jeopardize all of this clinical accuracy that we have done so far for home sleep apnea testing on cost of simplicity? Or can we do both? Can we actually make use of both worlds? Today I'm honored to present Dr. Erna Sif Arnardottir, who's with me here today, Director of Reykjavik University Sleep Institute, President of the Icelandic Sleep Research Society, and board member of the European Sleep Research Society, and project leader of the Sleep Revolution project, which is a project that aims to change the way sleep diagnostics are made today. Erna, welcome to this webinar.
Thank you.
I would just want to welcome you first and foremost, and I'm happy to see you, and I'm very much looking forward to see your presentation. And just for our viewers here, we will have a live Q&A session right after Erna's presentation. And we will also have a poll right after Erna's presentation. And please feel free to reach out to us here through your Q&A button down below. If you have questions, I will try to get through most of them, but I will most definitely have to pick out questions. Without further ado, Erna, take it away.
Thank you very much, Snorri. Now I'm going to share my screen. Make sure this all works. I assume you can see my screen now. Yes, excellent. So Nox asked me to talk about this important topic, which is very close to my heart. So, and like Snorri was saying, there is a reason why we're talking more about home sleep testing now than maybe we would have done a year ago. But aside from COVID, there is a huge need for home sleep testing and having simpler ways of doing diagnostics, because we appear to be in a sleep apnea pandemic as well, where nearly 1 billion people worldwide are estimated to have sleep apnea. So this is from the Benjafield et al. Study with mild to severe sleep apnea. And this is actually only for adults. So this is excluding the children and others who may have sleep apnea. So sleep measurements in the last 2 decades have been progressively shifted to the more home setting. And this can be then type 2 PSG studies, type 3 studies, where we will discuss those a bit later, as well as the type 4 studies, the simplest ones. And of course, the wearables, which we will also mention briefly. And the problem we have with these 1 billion people out there who may or may not have sleep disordered breathing in need of treatment, as well as those who are habitual snorers. This is actually an addition to the 1 billion people in the Benjafield study that may have some symptoms, sleepiness, and other healthcare issues due to heavy snoring. So we really need to find a better way how to decide who needs treatment for sleep disordered breathing than we currently have. And I will explain that a bit, why I think that that is so. This is our review paper that we published last year with Dr. Pavernacci as the first author. This was published in the Journal of Sleep Research on the rise and fall of the apnea-hypopnea index. So this is a review and critical appraisal of this index, which we keep calling the AHI, even though we have changed the way we calculate the AHI a number of times throughout the years. And there are different thresholds that are for different disease severity. And the whole story of the AHI is not as simple as I thought when I started in sleep research, that's for sure. So I recommend you read this paper if you're interested to know more about the AHI per se and why that can be problematic. But what happens if you diagnose a person with an AHI above a certain threshold, for example, 15, which is the typical threshold that we say that someone needs treatment. People can have symptomatic OSA or asymptomatic OSA, and we still always want to treat them if they have an AHI above 15. If it's between 5 and 15, then it depends on the symptoms usually. But normally, even if you are asymptomatic with AHI above 15, we want to treat. And what happens then with the symptomatic OSA as well is that you can have people who are treatment responsive, or that their symptoms are actually because of OSA. But we can also have coincidental OSA. That is that people, they have hypertension and their cardiologist sends them for screening for sleep apnea. And in that test, they happen to have sleep apnea. But even if you do treat them, they actually don't feel any changes or any differences. So a part of the people we are treating today for sleep apnea, they may just have coincidental OSA and they don't feel any differences, even though we do treat them. This could be, for example, an elderly person, an 80-year-old, which happens to have an AHI above a certain threshold, and we do treat them, but we're not sure if we're making an impact or not. The other ones are then the snoring ones, which will always be below this threshold, and they usually will then never get treatment. So as I say, I recommend you read this paper. But I like this picture actually, and this quote from Mark Twain: "To a man with a hammer, everything looks like a nail." So here we have a screw, which the nail is going to pound on, because we're saying this person must have sleep apnea. And I think we need to be careful also when we do sleep diagnostics, that we don't simplify it to such a manner that we only do an objective sleep study, a home sleep study, and we don't actually talk to the patient. We don't get the subjective patient data. And in all of our simplification now, to try to work faster and do things better, we also need to make sure that the questionnaires and the patient experiences are recorded. And we can also do this in a telemedicine way. We can do all of this online. We want to know if a person has daytime sleepiness, other daytime functions, fatigue, etc. We want to know about their sleep hygiene. If they have other sleep disorders, you can have comorbid insomnia and sleep apnea, for example. And if you have both, you would want to treat both disorders, not just the sleep apnea. If a person has comorbidities, we need to know this. And we want to follow people. So if we do prescribe CPAP treatment or any other treatment for sleep apnea, we do want to know if people are treatment responsive or not, so that we can make sure that we are actually helping the patient. And this is, of course, in addition then to the objective sleep measurement. But I do think it's very important that we don't dismiss the subjective data and rely only on what we call objective sleep data. So one of the questions that Nox asked me if I could answer here is why the gold standard is still so ineffective, and what can we do? What can we throw out of the gold standard or the PSG without jeopardizing quality? So this is a tricky question, but we are working on this in the Sleep Revolution, which is this 4-year Horizon project that we are just starting now. It's actually 37 centers in Europe and Australia, which are participating together in this project. And one of the things we are doing is we are planning to move the diagnostics from the hospital to the home. So we will be, instead of doing an in-lab study for one night, the patient may not sleep so well with a different pillow, different bed, different noises, etc. And these huge waiting lists, of course, to go for an in-lab sleep study, that you do this at home. And of course, other centers have been doing this with type 2 studies, but it still requires the patient to go to the hospital to have the equipment set up. And as we've seen, for example, during COVID, this may not always be feasible. So can we then, instead of having a sleep technologist set up the sleep study, can we have it self-applied? Then the patient has a video. Here there's an 8.5-minute video. The patient set up the electrodes himself or herself and sleeps with it then for 3 nights actually, instead of 1. So that we also then have all of this variability between nights that we can have for the sleep apnea severity. We can have a huge impact on someone with mild, moderate sleep apnea or snoring, which night did we actually record, if they would get treatment or not. And also if someone finds the equipment uncomfortable, they may sleep much better the 2nd or the 3rd night. So this is one of the things that we will be working on in the Sleep Revolution. We actually already did a validation of this in children as a part of our previous project. And there we actually had then 2 PSG devices on the over 100 children, which we were measuring. So they had this frontal setup for the electrodes, which are then the self-applied ones, as well as the traditional PSG, then on the top of the head and at the back. And we have submitted this first paper, and the results seem quite promising for this self-applied setup. And we will then do the same in adults. If we then ask ourselves, how accurate is the data that we do gather for home sleep testing? And at what point in home sleep apnea testing are we sacrificing too much data for simplicity? So I wanted to try to answer these questions over the next couple of slides. First of all, if we look at type 3 devices, they usually just have the same sensors as you would in a PSG, but you are not recording sleep itself. But you have the same sensors for respiration, for oxygen desaturation, respiratory movements, etc. And typically these are used then for patients with a high pretest probability of OSA. And here the subjective assessment comes in very strongly. So you're not asking someone to go for a type 3 study, which also then has insomnia symptoms, a lot of comorbidities, etc., which will not be a good fit for this type of device. But what we do need to remember with these devices that we do not have the actual sleep information, of course. So the index time for the apnea-hypopnea index, if you have 30 events per hour of sleep, what is sleep? You can both actually overestimate the sleep. If a person lies awake, has insomnia, for example, or just stays awake for a long period without moving, we can think the person is asleep. And we can actually also do vice versa, that we think someone is awake while they were asleep. So both can happen. And we cannot assess then hypopnea as causing arousals only. So if we are using the recommended AASM rules for scoring hypopneas, we can actually only score the hypopneas with a desaturation. So here we will underestimate the disease. So for people with milder disease, this can have a huge impact. Similarly, if a person only has OSA during REM or upper airway system syndrome, again, for all of these milder patients, we may need to do a full polysomnography or assessment of sleep. And this could then, in the future, hopefully be the self-applied PSG for 3 nights instead of the 1 in-lab study. Also, of course, if we do a type 3 study, we cannot detect other sleep disorders that can be measured in a PSG, like a periodic leg movements, bruxism, etc., unless we put in extra electrodes. For me, the bigger issue for simplicity than type 3 devices is type 4 devices. And this would be if you have, for example, only an oximeter, as is done in some countries, or if you're using the PAT devices, such as the watch PAT. These are the devices that measure the peripheral arterial tone. This is from a meta-analysis on how the PAT technology works to diagnose obstructive sleep apnea. And at this point, this was in 2014, there were 14 studies already been done with over 900 subjects. And on average, the comparison with PSG, so for the AHI, was quite high. So it seems on average, if you use this type of technology, that you can have pretty good diagnostic accuracy. But I wanted to have some caveats to this that we need to think about. First of all, as is listed quite well in this paper, there's a lot of potential confounders. So if you're going to be using this technology, you can, for example, you should not include people with hypertension, which is typically about half of the sleep apnea people coming in for diagnosis. It may not work so well for people who are younger, and there's a lot of issues with a number of different medications and arterial stiffness, etc. So even though this works well on average, this may not work so well for an individual patient. And we need to think about the individual patient, of course, when we're doing diagnostic studies, because the patient may only get one study. And here is a recent paper where there was an automatic analysis from this PAT device to assess the AHI versus the polysomnography. And this is a bland Altman plot. So we have the average AHI from the two devices, and then the difference between the two on the y-axis. And you can see, so on average, it's fine. But for the individual patient, for example, here you have a patient with an AHI of 30 on average, but the difference between the devices is 40. And it can go both that you are overestimating it or underestimating it hugely. And so this is not, for the individual patient who gets a number like this, this is not acceptable. Because we do need to think about, for the individual patient, if the sensitivity to detect true OSA or having no OSA, how good this is. And if we think about, for example, 80% sensitivity, which sounds pretty good, you still have then 2 false negatives. So that you have 2 people who actually have sleep apnea, which if you have an 80% sensitivity, 2 of 10 patients will then not be diagnosed with OSA, even though they really have it. Same for specificity. Here, for example, if you have 70% specificity, this means that you have 3 people who do not have OSA that are regarded to have it. And we've had incidents like this coming up, for example, here in Iceland, that a person had an inadequate home sleep study, was diagnosed to have sleep apnea, which that person did not have, tried using CPAP for a number of years, and the medical or the healthcare system never listened to this person when she was saying that she was still sleepy and tired, because she was always deemed CPAP failure. So she never got the proper diagnosis. She had a completely different sleep disorder. She didn't have sleep apnea, but because of this sleep apnea stamp and the CPAP failure stamp, she never actually got the relevant treatment. So this can have a huge impact on some of our patients. Also, if we're using something simple like the PAT signal to estimate sleep stages, again, we need to be careful. Here, for example, from this same paper published last year, the REM sleep time, there can be a difference of up to 80 minutes or 100 minutes in the REM sleep time on the night, based on the automatic analysis from this PAT signal or the PSG. And for 25% of the night with REM, this is a huge amount of minutes that it can differ. On average, it's fine though. So I think in general, when we are not measuring the actual signal, we are not measuring breathing. For example, if all of the measurement is on your hand, you're not measuring breathing. You're definitely not measuring brain waves. And that's of course the same then for type 3 devices when you're not measuring brain waves. And if it is a black box analysis, you get input and you get a number that pops out, we should always be careful. And we need to think about all the potential limitations. And this is then, of course, the same for the wearables, where a number of physicians have patients coming to them where they are telling them they don't sleep based, or they sleep poorly based on their wearables. And the doctors don't really know what to do with the information because it's probably not accurate. Another thing I think we need to think about more when we are validating this type of devices is we need to look at the temporal overlap of events. And I'll explain this, what this means. We are actually publishing a paper on this, which is in submission currently. First of all, so many papers they will publish, on average, something looks similar. but you want to see, for example, for sleep stages, what was considered REM in a PSG? Was that same epoch considered REM in a type 4 device or a PAT or a wearable, or was the REM period somewhere else? Because even though you can say 20% of the recording was REM, you actually want it to be in the right place, where the apnea events were, for example. And if you have, for example, sleep apnea events, you want them to be labeled in the right place. So if the PSG says the sleep apnea event was where the pink boxes are, and if the new device you're validating puts them in a completely wrong place, are we still okay with that? Or do we want it to be in the right place? I would like it to be in the right place. So we will be validating in Sleep Revolution, we will be validating the wearables, and we will be looking at this in this way, see if we can temporarily connect things or not, and improve things that way. If we do want to go beyond the AHI, we want to do better for our patients and have more than this one number to diagnose them, which I think the field is definitely moving in that direction. We're looking at different phenotypes, different response to treatment based on your study. I think we need more than a simple type 3 or type 4 measurements for many of our patients. And we need to remember that many of our subjects, many of our patients, they will only have this one sleep study performed. Depending on that sleep study, they may or may not get treatment and not get treated for other diseases. And we need really high diagnostic accuracy and reliability. So the sensitivity and specificity of our studies should be as high as we can have it within a sensible framework, of course. And if our devices what we use for our patients can only count AHI, and we can't know anything more about the patient or what's going on, how can we improve diagnostics for the future? I don't think we can. We're kind of stuck in an AHI loop then, where we just keep on going forever talking about the AHI and nothing changes. So even though we have so many patients and so many people waiting for services, I really like this quote from Liborio Parini, who is my friend and a collaborator, which is, don't throw the baby out with the bathwater. So even if we have so much to do and there are so many patients waiting, we shouldn't move to such simplistic ways of doing things that we actually lose all of our diagnostic accuracy and good way of doing things. And here, I also recommend reading this paper from 2018 from one of our collaborators in Sleep Revolution, Randerath and other co-authors, where they're looking at the respiratory events, the AHI and other signals that we can look at in the sleep study, looking at to decide sleep apnea severity and if you need treatment, you not only look at the respiratory events, you also look at the chronic end organ impact of those events and the acute systemic effects. And if we want to do that, having just a type 4 device will not get us far. So I think this is my last slide. I think we are in a place now in sleep that we had moved from an immature science to a so-called normal science, where AHI was our gold standard and in-lab PSG was the gold standard, and we've been trying out simpler things. We are realizing this is not working so well. We need to do better. So I think currently we are in a crisis where we're looking at new options, new ways of doing things, and we are starting a revolution. So, and this revolution will change the way we see the world and the way we do things, and hopefully in some years, this will become the new normal science. And we in Sleep Revolution hope to be a part of that change. So, thank you very much.
Thank you, Erna, for a very interesting talk. Before I start asking questions, again, I would like to point our attendees to use our Q&A function, but I will be throwing a poll at you now, which we will review a little bit later. So I'm gonna launch that one now. So you should be seeing a survey now in front of you on your screen. But while we're waiting for our attendees to answer, I would like to ask you a little bit more about going beyond the AHI. I know that we have been talking about this for a while now. We see the limitations that the AHI has, and I would just like to ask you, I mean, where do we stand today? Because we have been talking about this for a while. Are we any closer to going beyond the AHI? And is there anything else that we should be, seriously discussing to replace the AHI, or should we augment the AHI? What's your opinion on all of that?
So this is an excellent question. And I think it's actually one of the big reasons that we got the Sleep Revolution grant, is that to be able to change diagnostic procedures and the way we do things in clinical practice, is that you need a lot of data and a lot of publications behind you. So currently we have a number of papers showing the limitations of the AHI, but we are not there yet to put in a clinical practice something that comes instead of the AHI or in addition to the AHI. I'm not necessarily saying we need to throw out the AHI. I think we can include it still, but we need to make a more composite marker. So we have the AHI plus something else, as has been done in some other, such as asthma and other clinical routines. But to be able to make such a broad change, you can't just say the AHI is not good enough. You have to show that something else is better. And for example, in Sleep Revolution, we are collecting over 30,000 retrospective studies from the ASARA network and other clinical studies that we have access to. And we will be collecting over 10,000 sleep studies prospectively. And I think we need data of this volume to be able to make an actual change and revolution. Otherwise, we're kind of stuck.
Okay, thank you for that. And maybe just another question, a little bit related to this one. Do you feel like the link between diagnosis and treatment is clear, or is it just you get the diagnosis of sleep apnea and then you are, on your way with your AHI index? Do you feel like your colleagues, your collaborators are on the way of linking better diagnostics to better treatment or better treatment outcomes?
So yes, I think we definitely need to move in that way, and you can see that a number of research centers are already doing this. How much it has gone into clinical practice, I think will depend a lot on countries and sleep laboratories. But if we see, for example, the cluster analysis that has been done in the ISAC, SAGIC, and in other places, we're seeing that people who, for example, have insomnia issues as well as sleep apnea, that they then should have a cognitive behavioral therapy plus CPAP. I think this is the way we need to move. So we are treating the individual, and we do personalized medicine instead of just apnea tick and then CPAP tick, so that we have just one pathway for the majority of our patients. There are a number of other things we may need to think about, like if you're claustrophobic, will you be able to use a CPAP mask, or do you need help before you can start using the CPAP? Do you also have restless legs, or are you just coincidentally finding OSA, and when the person starts CPAP treatment, they don't feel any differences? Do we need to help them more? Do we need to do something else for them than to start them on CPAP? So there again, even though we have the devices and we have telemedicine, which can tell you if a person is using their device or not, you don't really know anything about the experience of the patient from that. So we need also then some questionnaires, interviews, or other things to follow up to make sure we are treating the patient, not just an index.
Mm-hmm. Okay, thank you. I would like to go through the poll results now. I don't know if you can see that, but anyways, I will just read them out loud as well. The first question asked, how well do our attendees trust HSAT devices to give an accurate diagnosis? Most of the answers, or 58%, were answered well, but 26 plus 9, 26 answered neutral, 9 answered not well, 2 not very well, and 5 on the other end very well. Your take on that, Erna? First question.
Yeah, I'm realizing when you read this out, it should have been divided if it's a type 3 or type 4, but that will impact the answer, I think, for many people at least. So I agree, at least with type 3, that for a person with a high pre-test probability of OSA, and if you're diagnosed with severe sleep apnea, I mean, you have severe sleep apnea very likely. You are measuring flow, you are measuring oxygen. So that should be pretty good. But if we have black box analysis, at least for me, I wouldn't trust it so well.
Okay. The next one, yeah, it's very interesting. Most of our attendees are using a type 3 home sleep testing, and some are using type 2 as well. And minority is using type 4, and 1/4 is actually not providing home sleep testing. So this is very interesting. Do you feel like we should be moving towards type 2 types of studies, or should we bring in a type 2B, or what's your take on that?
I think type 2B, which would be, I guess, the self-applied polysomnography, would be, for me at least, I see huge potential in that area, because there you are not so reliant on this very limited resource we have, which is the in-lab sleep study and access to a sleep technologist putting this on. So I see a lot of potential for self-applied sleep studies, actual sleep studies. We call it home sleep apnea testing. We have to call it a sleep study, but you're not actually measuring any sleep. So I really would like to get the sleep back into the majority of sleep, home sleep testing.
And the third question here, Dr. Paul, it seems like our attendees are believers in general of wearables in clinical routine. We actually also have a question in the Q&A section. What is your view on sleep tracking wearables, and how do they fit in the future of diagnostics? It's a very interesting question.
That's an excellent question. So one of the things we will be testing in the sleep revolution is that people sleep with a wearable and a PSG at the same time. So I'm really curious to know what these wearables can actually do. Where can we trust them, and where are they maybe not working so well? So at the moment, I mean, I slept with one of these wearables the other day, and it told me I had 60% deep sleep, and that this was awesome, because 60%, and I should, even try for more, but there's no way I had 60% deep sleep, and this would actually not be great if I did, because it sounds a bit disturbing. So at the moment, I am very hesitant about them, because they are usually black box technology. I don't know where I don't really know what they're calculating from. It's just something on my hand, and I get a number on my app telling me my sleep quality is X and Y. And here, I think we need to do the same as for the type 4 studies. We need to look, we need to get the raw data from the wearables. We need to look at them in the same time as we have a PSG, so that we can make sure the algorithms work, and know whether they work or not. I also had a reflective oximetry on this wearable the other day, and I got 94% oxygen, and it told me that my oxygen was below average, and I may or may not want to consult a doctor about this.
We're giving you as well. We're giving you diagnosis as well. We have plenty of questions here. So one of the questions is, adding new sensors or more sensors to home sleep apnea testing or home sleep testing, like tracheal sounds, cardioballistography, cardiopulmonary coupling, heart rate variability. Your take on that? Yeah,
that's an excellent point. I definitely agree. So what we are going to do in Sleep Revolution is we're going to look at all of the data we get from these tens of thousands of studies, and we're going to see which are the crucial parameters to get the needed diagnostic info. So we do hope that we can simplify the study at least some, because it is a lot of sensors. And many people who, when they go for a sleep study the first time, they are really surprised that they're supposed to be able to sleep normally with all of this stuff on. So even if it is at home, they are still, it is still a lot. So it would be good if we can simplify it somewhat. And if we are adding sensors, I mean, the cardiopulmonary coupling, heart rate variability, cardioballistography, this is all something that we can easily do if we have a self-applied type B study. Tracheal sound would be an additional sensor, but if it shows real validity, then it could be added. It would be a relatively simple thing to add. So no, I agree, but we just need to really show concept of proof that if you're going to add something, that it is really clinically needed.
There are also questions regarding type 2 PSG and failure rate. Your experience in that self-applied type 2?
Yeah, so we are just getting started with that. So I will hopefully have a publication. We will have a publication on that later this year. So I will have to postpone answering that. We have currently, what we've done in these double setups is that we had, of course, a sleep technologist then setting up both the normal PSG and the self-applied. But I do know that Decode Genetics in Iceland, they have already been doing over 3,000 of these. But I don't know if they've been capturing the exact failure rate yet. But it's people, general population who are doing this, and it seems to be going well overall, at least.
Mm-hmm. And this maybe brings a question from my end. I mean, from the general population, and we have had this dilemma for a long time. How do you actually prioritize who should go into the lab and who shouldn't, and especially these times? What's your take on that, and what's your expert opinion? What should you use to prioritize?
So here I think again this patient interview and the subjective data is crucial, because you do want to know if the person also has pulmonary disease and may or may not have some issues where you would like to have CO2 measurement in addition to the more traditional things. If you have obesity, hypoventilation, for example, you would like to have a CO2 measurement. If there is likelihood of other sleep disorders that are more rare, where you would like to test with a video. If a person has bruxism and you would like to add some sensors at least. So here I think for people who are less experienced with sleep, they often think they can just get a home sleep apnea testing. They can just get a type 3 device, and that this is enough to do sleep, patient sleep, work with patients on their sleep. But this is, in my opinion, definitely not enough. You also have to have the experience and the subjective experiences of the patient. And then you can make the decisions to put them in the right place. For example, if you have only the PAT analysis and you have someone with arterial stiffness or someone who is younger than 45, I would never put them into that type of study.
Mm-hmm. Okay. We have also one very interesting question here regarding how important is data derived from CPAP masks to manage OSA for you? And if there was a pill available instead to treat OSA, would you lose important information from the CPAP device? Because we were driven by the CPAP industry in treatment, on the treatment end, at least. It's very valuable information that we're getting from the CPAP devices. So,
So I think we need to be careful in trusting the PAP devices too much. The algorithm in there is great, and it helps a lot with making decisions to see if the AHI has gone down. But we have, when I was working at the hospital here in Iceland, we often did also simultaneous in-lab studies. And there we could sometimes find a lot of, for example, hypopneas that were not then recorded by the CPAP mask. And here we need to remember again, we don't have, it's limited information that you're getting from the mask. You're at the same time pushing in a lot of pressure or air under pressure, while you're trying to get subtle differences in flow from the patient. So for an apnea, it's likely mostly okay. For hypopnea, it's not necessarily so. So if a patient is still experiencing sleepiness, tiredness, or not feeling any differences from treatment, I think they should definitely always have a sleep study using their PAP, where we also measure them, the oxygen and the respiratory movements at least, to make sure that they are actually being fully treated for sleep apnea. As I say, we saw this a number of times. So it's not, I can't give you a percentage. There may be some in the literature, but there is a significant portion at least of patients. I didn't quite catch the second half of the question.
If there was an alternative treatment or pill or something instead, would you lose important data or information from the CPAP devices? I mean, that you are relying on today, maybe?
Yeah, I mean, you would then, but here then you could make sure that people are taking their prescriptions if they're going to the pharmacy and getting new prescriptions, or you could regularly send people a questionnaire to check how they're doing. Are you still taking the medicine? Are you experiencing side effects? So here I think we also, again, we need to use the technology. We will be building in Sleep Revolution patient management platform that we can, people can see their own data, people can answer questionnaires, they can see how they did, if there's a change in questions, if there's a change in objective sleepiness testing, PVT, etc., so that we can have this dialogue with patients and people can see their own data. This encourages then participation and that they are responsible also for their own treatment. And I think this is the way we need to move in the future. So because we can't also be limited just to CPAP treatment for the future. We already have the mandibular advancement devices. Some of them actually have, you can follow if people are using it or not. But we also, I think, need to move to lifestyle treatment. We can do exercises of the upper airway. There's a lot of other treatment options, especially for people with milder disease. And I don't think we should shy away from them just because they don't give us the how well people are using it. We just need to find ways to measure that.
Okay. I think we have time for one more question before we wrap this up. Unfortunately, we have a lot of questions. Maybe we can try to answer those through writing afterwards, or try at least. But there is one question here about how do you feel about the general trust in the sleep industry on automatic analysis made by AI versus manual scoring, and what should happen to increase that trust in order to decrease diagnosis time and etc. Because you're talking a lot about black box analysis and that you don't trust them, and I think a lot of what is being developed on the industry side is going to be black box analysis. Yeah. So yeah, what should happen to increase that trust?
It's an excellent question, and it's actually one of the ones that we were talking about a lot when we were doing the Sleep Revolution grant. And one of the things that we want to see is that, first of all, that we work together. So the people who are making the analysis work with sleep experts, so that we are not doing this in two separate corners. That we talk together, we know what the issues are, and we check on things together. And second of all, that the person who is scoring the data or looking at the data, that they can see when the automatic analysis is considered to be, high accuracy, that it's what do you call it, when, when the, sorry?
When it's confident
Yeah, exactly, the confidence of the algorithm. If the confidence is really high, or when the confidence is really low, that you can actually see this visually when you're scoring. And then you could, for example, go to all the areas where the confidence is low, and you could score those. But after a while, maybe after you go through the whole recordings and you always see that when the algorithm confidence is high, that it is actually pretty accurate, then you can start to become quicker. Another thing I think we need to work on is that we also have issues with just score agreement, just manual scoring agreement. So we need to have many people score the same recordings and then train the automatic analysis on that instead of just on one person. Even though I think my scoring is awesome, it may not be that Snorri actually agrees or someone else who is out there. So I think we need to train on many, and we need to find the gray areas in scoring and deal with those also. Because there's a lot of gray areas, unfortunately.
Well, thank you for this, Erna. Before I let you go and close this one off, I want to remind everyone that we have our next webinar on the 7th of April on artificial intelligence in sleep, actually, and how the technology can assist sleep specialists in advancing sleep medicine. So we will send you a post for all of those that are attending here. We'll send you an email with a link to that one. And as well, I wanted to tell you a little bit about a new initiative that Nox is launching now, called the Nox Expert Community. This is a community we want to recruit specialists from the sleep into to help building a dynamic community of experts advancing sleep medicine. We want to do this together with you guys. We want to engage with you. We want to learn from you. We want to show you things that we are building. We want to involve you in user testing. We want to involve you in exclusive webinars. But we have to do it with you. So we will be sending a link to you as well on the expert community. You can read all about it and see if there's something in there that you would like to participate in. But other than that, I don't know how it works, but we'll try to answer some of the questions that we didn't answer today that were in the Q&A section. But yeah.
There are two comments in the chat, Snorri, that you may want to answer, which is whether the recording will be available afterwards and which email people should use if they want to send additional questions.
That's a very good one. So for email for questions, I recommend that you use info@noxmedical.com. Just in the subject line, refer to the webinar, and we will take care of that. And the recordings will be sent to those that registered 1 or 2 days from now. We just need to cut it and make sure it's looking good. Yeah, that's all I think. I wanted to just end this webinar by thanking you, Erna, for participating. Thank you very much for your time, and all of our attendees as well. Hopefully, I will see you all again on 7th of April, where we will have Dr. Jón Skírnir Árnason, who is here at Nox. He will talk about artificial intelligence in sleep. Thank you.
Thank you.